to get participation for today. So what we're gonna do today is something we did before in the last time we did virtual rounds, which is a case that we're gonna all solve together. I haven't seen this case. I only looked at the HPI for the first part to make sure that it is a case that we would be able to do, and I think it is. And so we're all going to solve it together. I'll put the link for the case. Let me see here. I'll put the link in the YouTube comments. And so it should be. Let me see. Who gets the chest pain in a 49-year-old? Right. So if you can't find the case, I'll be sharing my screen as well. So I'll be doing it along with you guys. And so if you have if there's something that we don't know or something that I don't know myself, I will we'll kind of look it up on the fly, so that way we can see what it's like to solve these cases. You can look at my approach as well. And then next week, we'll go back to how the format was before. This way, this will help us, because I want you guys to also look through the abdominal pain section as well, because the next few may be more involved in the GI system. They may also have a component of cardiac, and then maybe some other systems. Any questions about that at all? Okay, so we'll go ahead and get started. You guys can see that okay?
Yes, okay.
Yes, okay, cool. So, like I said, I don't know what the outcome of this case is, so I'm hoping it's something that we can actually do together. We've done I think the other two chest pain cases, so hopefully this is new for everybody. Okay, and then again, I will be calling on some of you guys just so that we get a little bit of feedback from you as well. All right, so let me just double check here. Cool, I think we're good. All right, so we have a 49-year-old female that comes to the ED because of chest pain. She was completely normal the day before. She woke up at 6 a.m., sudden onset, left-sided chest pain. It's been constant, radiates to the center of her chest. It's not worsened with exertion, movement, food, activity, or respiration. She has shortness of breath and chills, but no cough, nausea, or diaphoresis. She took 400 milligrams of naproxen without relief, so it's an anti-inflammatory. The pain is persistent, prompting her to come to the ER now. She's never had chest pain before this episode, and no known history of cardiac or pulmonary diseases. Okay, so Emma, right off the bat, how would you characterize this patient? Does she sound like she is somebody that is sick or that is not sick?
I would say sick because of the sharp chest pains.
Okay. And then what about her demographic? So she's a 49-year-old female. And this may be a bit of a harder question. Is she on the younger side, on the older side? Is she somebody that would have dangerous things going on in her chest or not?
I would say she's in the middle, but it's definitely an age where I would start to raise a little bit concern. The 400 milligrams of naproxen is interesting to me, but there may have been something before she had taken that may have been causing this.
Yeah, possibly. So if she had taken some other medications before, it can possibly be causing it. The 400 milligrams of naproxen is a bit on the higher side for naproxen. And so the fact that she took 400 milligrams, that's basically 2 Aleve at one time. So it's not super high, but it's on the higher side. So she took 2 at the same time and it didn't improve her pain. So do you think that tells us it's more a serious issue or not so serious?
I would say it's more of a serious issue since that didn't relieve her problem. But on the flip side, she doesn't have a history of cardiac and pulmonary disease. So whatever it is something new or very particular.
Yeah, so that's actually a good point, right? She has no previous history, so it's either a new representation of a cardiopulmonary disease, or she may have something that has been undiagnosed. So yeah, that's actually a very good point. All right, and then Jeanette, in terms of the pain being constant, radiating to her chest, not worsen with exertion, movement, food, activity, or respiration. What is that? What do you think about that? What would be something? What possible diagnoses you would think about with that?
Honestly, since it's not worsened by food or exertion or movement, I'm honestly not sure. It could be some. I am honestly, I have no idea. I'm really not sure.
No worries, no worries. So let's think about it real quick. So pain that gets worse with movement and better with rest. What did we say that's usually because of?
I'm not sure. This is my first session with you guys.
Oh, no worries. So we usually say it's because of a cardiac issue. So the way that I usually explain it is if we have a person that starts to, let's say, run, right? Their heart starts to beat faster. You need more energy and blood flow to the heart. And so if you have arteries that are already closed off, and they try to dilate even more, the more they try to dilate, it won't matter because they're plugged up, and so you can't get enough blood flow to areas of the heart. And so as those areas of the heart don't get enough blood flow, you end up getting pretty much ischemia, or the heart cells start to die off because of the lack of oxygen, the lack of energy. So the demand of the heart goes down, the supply is not able to match that, and so you get that mismatch, which causes that injury to the heart, which is something like a heart attack, right? So the fact that it's not worsened with exertion tells us it's probably not a heart attack. We can't rule it out because everybody kind of presents differently for heart attacks, but it's something to keep in the back of our mind, and it's a little less likely that it is that at this point. Okay.
Okay, thank
you. So we can move on. This works. There we go. All right, so review systems, and we're gonna go with we'll go with Ashleen. All right, so she has chills. She thought she had a fever, but did not take her temp. Nothing on the skin. Head and neck. No recent URI symptoms. Nothing as per present history of present illness. So I think she was saying that she has shortness of breath. Is that right? Sorry, let me double check.
Yes, it does.
Okay, awesome. So the chest pain, no palpitations. She has dyspnea when climbing stairs since chest pain began. So she's getting shorter breath as she goes up the stairs. It resolves quickly with rest, not worsened by laying flat. So that's something that we're gonna talk about. No abdominal pain, nausea, vomiting, appetite, bowel movements are normal. Minimal spotting after recent menses. So she just finished her period. It looks like she has no current musculoskeletal symptoms, although she has noted intermittent left leg swelling and discomfort for the last year. There's no history injury or recent immobilization. The last time she had swelling and discomfort in her leg was about 10 days ago. Neuro and psych are non-contributory. So you can go ahead and take whichever part of that you want to focus on. I think I said Ashleen, right?
I would say based off of the cardiovascular section, so we did talk about chest pain. They also said dyspnea, so I think, yeah, you mentioned that it was shortness of breath, climbing upstairs again, so that's something that's maybe a little bit worrisome because it's just an everyday activity. And you said that it resolves quickly with rest, so that's a good sign because it's not worsening or anything.
So let's kind of take that part real quick, because we on the last kind of slide section, we said we were talking about it wasn't exertional, right? So her pain, when she got the pain, it didn't worsen with activity. So that made us think, okay, it's maybe not cardiac, but now she's getting shortness of breath when she's doing some activity. So as she's climbing upstairs, she's getting short of breath. And that shortness of breath resolves quickly when she's resting. So does that tell us that it may still be something cardiac, or no?
I would say yeah.
Okay. Yeah. So that is a little bit of a red flag, right? She's doing activity and getting short of breath, and it's getting and as she rests, it gets better. What about the other thing that stood out to me? Was Where was this? It was the musculoskeletal area. So what about the leg swelling? What are your thoughts about that? And we can go with Caitlin. Caitlin, what do you think about that leg swelling?
I've like seen this before and I'm not remembering exactly what it means, but the leg swelling has something to do with like the retention of fluids. So I'm thinking like something's not circulating the way that it should be because of that buildup.
It's possible. So there's something that may be obstructing, especially if it's been intermittent for the last year. And she's had a little bit of pain. What about Philip? What do you think? Or Andrea, if you're on, what do you think? It looks like you might just be on YouTube. Emma?
A pulmonary embolism?
Yeah, so kind of explain your thinking there.
This would cause lower extremity swelling, which would explain the legs swelling. She has increased respiratory rate or I'm assuming she has the increased respiratory rate from shortness of breath, just doing stairs and typical things. So those two things. Oh, and then obviously the chest pain.
Yeah, so walk through how leg swelling is associated with a pulmonary embolism. Like what's the physiology behind that?
So from what I understand, there's going to be a pump failure. So there's a blockage in a clot in the pulmonary vein, which would block the right atrium, if I remember correctly.
So so close. So it's the pulmonary artery, right? So the arteries go away from the heart, veins come back to the heart. So within a pulmonary embolism, you have a clot that gets lodged in the pulmonary artery. So the vessels that go from the heart to the lungs, and so there's a clot. Let me see. So within the heart itself, you have a clot that comes to the heart. It gets pumped out into the areas of the lung. These clots lodge into the pulmonary arteries, and so you have part of the lung that does not get blood flow, and you can't oxygenate that blood. And so that part of the lung can, depending on how big the clot is, it can become damaged, ischemic, and yeah. So in terms of where this clot came from, right? Because we're saying that there's a clot that somehow magically appeared in the heart and now goes to the lungs. So can you relate that back to the case and what we're talking about here?
So there would be a blockage in blood. There would be no blood flow through the legs. So
yeah, so the we're saying that the clot may have come from the legs, right? So there's a clot in the leg, in the veins of the leg, and that may be the cause of her intermittent swelling over the last year. That clot gets dislodged from the leg for whatever reason, travels up through her system, and into the right side of the heart. The heart squeezes that clot into the lungs, and now you have a clot in the lungs and a pulmonary embolism, right? So that is a very good pickup. It's very possible that this might be a pulmonary embolism. Good. Anything else here that you guys picked out? I don't think there was. Okay, so let's go to the next slide. So, past medical history. So she has menorrhagia due to uterine fibroids. So that just means that she's been having heavy bleeding because she has fibroids. She has iron deficiency anemia, endometriosis, right breast fibroadenoma, no history of blood clots or clotting disorders. Let me see. She had a history of laparoscopy and lysis of adhesions from endometriosis, tubal ligation, excision of breast fibroadenoma, no medications, no allergies. Mom recently diagnosed with stage 4 colon carcinoma. Brother has schizophrenia. No alcohol, tobacco use. She used cocaine in the past and heroin, quit more than 20 years ago. She works for the hospital and food services department, no recent travel. Okay. So, what, Morgan, what in there is important or what stood out to you?
The first thing that stood out to me was the iron deficiency anemia, because doesn't that have to do with like red blood cell count?
Yeah, so the iron deficiency anemia is pretty much she's anemic because her red blood cells are a bit lower, her iron levels are a bit low. Is there anything in her medical history that would possibly explain that?
Probably. You mean from like the last slide, like what we just went over?
Oh no, just kind of what we see here. Is there a reason why she may have low blood counts? So,
I'm not sure.
so menorrhagia. Do you know what that means?
I don't.
It just means that she's having heavy periods. That's pretty much all it is. And so she has uterine fibroids. So fibroids in the uterus. Let me pull this up. So uterine fibroids kind of look like this. They can be on multiple parts. That's kind of small. That's even smaller. They all are pretty small apparently. So they can be on different parts of the uterus itself. And they're these little growths that they're not cancerous, right? But they can bleed pretty easily. And so people can have pretty heavy periods because of these fibroids. And so when they bleed, and especially if you have a long history of heavy bleeding, you can get anemia. And so her medical history, yes, it does show anemia, but I'm assuming that's because of her heavy periods. She has no history of clotting disorder, which is going to be important. Why do you think, Morgan?
Can you repeat that?
So, so she has no history of a clotting disorder. So why do you think that's important?
Because that shows that the blood flow is normal.
Yeah, so that shows that, there's nothing that's really going to predispose her that we know of to a blood clot, right? Because at this point, And we kind of probably should have talked about what our most likely diagnoses are. But at this point, it looks like something with the heart, maybe a pulmonary embolism. And so having or even like a heart attack, having something that predisposes you to clotting is going to make you higher risk of developing those things. And so knowing that she doesn't have a clotting disorder is pretty important. Awesome. So let's go with Crystal. What else in here is pretty important? Or is there anything important in here?
I think that the family history is important.
Okay. Why is that?
Because it shows that her mother was diagnosed with colon carcinoma, so it's possible that perhaps this is some sort of metastasis.
Yeah, so you're saying that because her mom was diagnosed with colon cancer and she has colon cancer, there's a possibility that she might have a cancer as well?
Possibly, yes.
Okay. And so what about cancer is important for this case?
Could you repeat that?
So what about having cancer or would be important for this case?
What symptoms would we look for?
Or why would that be an important thing to know for this patient?
So that we could provide treatment quickly before it becomes stage 4.
Yeah, I mean that's a good point. Yeah, but cancer. If we think about Virchow's triad, right? If we're thinking about something like a pulmonary embolism, so if we remember. We remember Virchow's triad, so that is the stasis of blood flow, endothelial injury, and hypercoagulability, right? So these are the things that make you more prone to clotting. That's a pretty decent picture. So these are the things that make you more prone to clotting. And so if you had, if the blood flow wasn't really moving as it's supposed to, something like in a blood clot in the leg or a DVT, right? That is the stasis part. If you then had endothelial injury, if you had a surgery, something along those lines that makes you more prone to clotting, that can produce a DVT that makes a pulmonary embolism. But the last part is a hypercoagulability. And so in cancer is one of the things that make you pretty hypercoagulable. You're more prone to clotting. I've actually we've diagnosed quite a few patients when I was in the ER by them coming in with a blood clot for no particular reason. Like we didn't really know why they had a blood clot until we did more workup and we found out they actually had cancer, right? So cancer is something that does provoke blood clotting. And so knowing that the mom was diagnosed with colon cancer is pretty important, just because then her risk may be a little bit higher. So that's a good point. Shivani, what in the social history, if we're thinking about somebody that is having, they're having shortness of breath, chest pain, what in the social history would be important?
Whether they smoke or not?
Yeah, so she doesn't smoke. What else in here? What else in here is important? So she's it says that she's a former cocaine and heroin user. Why is that important? Why do you think? And it's a bit of a harder question.
But you don't use cocaine and heroin like breathing or anything. That would be IV, right?
So cocaine, you can snort it, right?
Yeah.
And then heroin.
Infections that could cause infections and HIV with the needle sharing.
Yeah, so it's possible that you can have an infection. Ashleen, you have your hand raised. What are your thoughts?
I'm not 100% sure, but could it increase her risk of having an MI?
Yeah, so with cocaine, you can absolutely have that increased risk, right? So cocaine can cause spasm of the coronary arteries, and they basically clamp down, and you don't get good blood flow to the area. So if you're doing exercise and you or any type of activity, and you have taken cocaine, your blood flow to the heart may not be where it needs to be. If she has a history of narrowing of the vessels in her heart, that's going to make her more predisposed to having that having an MI. So the cocaine is super important. She did use about 20 years ago. We're assuming that she hasn't used again. So it's going to be a little less relevant for the cocaine part. But the heroin is actually super important. Crystal, do you know why that the heroin's important?
It messes with the electricity within the heart.
Not necessarily, right? So it has to do with how we're saying the heroin's being used. So so let's say she's injecting heroin. She was in the past. She was using it IV. Why is that important?
Would it still remain in her bloodstream?
Not the heroin. Not the heroin. Emma, what do you think?
This may be a bit of a stretch, but would it damage the vessels or cause like a scar tissue to prevent flow?
Not necessarily. No, but that's a good thought. Shivani, do you know? Why would heroin use if she was using it IV? Why is that important?
I have
How is
no
that-
idea. I don't know.
Okay, so good. So then we can all learn together. So it has to do with endocarditis, right? So do you know what that is, Shivani?
Yes, infection of the heart lining.
Yeah, so it's an infection in the heart. And so infectious endocarditis, what that is you have actually, yeah, so this is a pretty decent picture. So you have growth usually within the valves of a bacteria. And so let me see here. So an infection happens within the heart a lot of times because of IV drug use. So if somebody was using heroin through the IV, if they're not using clean needles, they can introduce bacteria within their bloodstream that can go travel to the heart, and you can have vegetations, or you can have basically the bacteria growing within the heart tissue itself on the valves. And so if you think of how valves work, right? So as the heart is pumping, the valves are closing up to prevent backflow, and so blood is going through that area. All these pictures are very small. So blood is going through the area, and so you can dislodge part of the bacteria. And so if you can have an embolus of a bacteria, so the part of that bacteria can break off, go to different portions of the body, include, if it's on the right side, that would include the lungs, right? And so you can be throwing off these emboli of bacteria. And so there's one part that is standing out to me right now, and I mean, I don't know if this is just like a red herring or something, and I don't know why this isn't working. Why isn't this working? Back in the beginning of the case, it did show that she was having a fever. And so in infective endocarditis, you can have this fever that waxes and wanes. So it comes up high, then it decreases, and so you have this recurrent fever.
But she used heroin 20 years ago. Would the infection stay for all that time?
Exactly. So that's the other part of it that I'm a little unsure of, right? So she used 20 years ago. So it's less likely if she had infective endocarditis for 20 years, it would have likely destroyed her valves. So I doubt it. I doubt that that's what's going on. again, she reports a 20-year history of sobriety, and we always want to trust our patients, but we do need to keep it on the back of our mind, right?
Yeah.
So, yeah. And then I think everything else here in this slide there's nothing else contributory here. Okay, I don't know why. Okay, so we'll go to the physical exam. So the patient appears anxious and in some pain. She has no cyanosis or respiratory distress. Her temp is 36.8, pulse is 107, blood pressure in the right arm is 130/72, respiration 16, O2 sat 96 on room air. So Elizabeth, what are your thoughts so far? What is your interpretation of the vitals?
Sorry, just a quick question. Can you hear me okay?
Yeah, we can hear you.
Oh, okay, sorry. I was having technology troubles, but okay.
No worries.
I think I'm still sort of leaning towards that like pulmonary embolism.
Okay, so just look at the vitals. Don't what are your thoughts about it? Is it normal? Is it abnormal? What's your interpretation of them?
The blood pressure does seem to be a little bit higher.
It depends on where her, I mean, she doesn't have a history of high blood pressure, so this may be a bit higher for her. What else?
The fever, the temperature.
Okay.
Could that be also another option?
Is that a fever or is it a normal temperature?
I think it might just be a normal temperature.
What about the pulse? Right, it was
Okay, I was gonna say, yeah, the pulse does look like it's higher as well than it should be.
Yeah, so the pulse is a little high. The breathing rate at 16, is that normal or no?
No.
It's normal. It's normal. And then what about the O2 saturation? So she's saturating 96% on room air. Is that considered normal?
Yes, that is considered normal. Or
okay.
It would be a little bit lower, but kind of still normal.
Yeah, so it's, I guess, considered normal. You're exactly right. The 96 is a bit on the lower end. If I saw 96, I wouldn't necessarily, by itself, I wouldn't necessarily be concerned. But the 96, she looks anxious. The pulse is 107. I would think, maybe there's something going on with her heart or her lungs. So good job. So let's see. We'll go with Jeanette afterwards. So no skin lesions or rashes. Mucous membranes are moist. Lungs are clear. No crackles or wheezes. She has an elevated heart rate, regular rhythm. No murmurs, rubs, or gallops. No tenderness. No JVD, so jugular venous distension. Normal carotid pulse. Abdomen non-tender, non-distended. Normal bowel sounds. Uterus is normal. No joint deformities. She has no swelling in the lower extremities, no redness, no tenderness. Cranial nerves are intact, and mental status, she's alert and oriented. So what else in there is important? Jeanette.
If you don't mind, it's actually Janet.
Oh, Janet, sorry.
You're good. Looking throughout, there's no. What does it mean when it says patient nares, like in the HEENT section?
Oh, so that's patent nares. That just means everything is open in the nose.
Okay. Then there's in the cardiovascular section, it says that there's an elevated heart rate, which we already determined through the pulse. Looking through everything else, there's no mentally she's fully aware. Neurologically, her nerves are intact. There's no vaginal bleeding.
Mhm.
There's no deformity. Her lower extremities have no pain. I'm actually not sure.
Yeah, no, so you're right. There's really nothing here, other than the elevated heart rate. So the fact that things are normal is pretty important for us too, right? So just thinking about the lungs, if the lungs are clear bilaterally, there's no crackles or wheezes, would something like a pneumonia be likely?
No, because when you have pneumonia, there's normally wheezing or like you can hear something in the lungs.
Yeah, exactly. And so it wouldn't be clear. And we're talking about endocarditis that may have sent a embolism to the lungs. And so when you have those emboli going to the lungs and there's an infection there, that's kind of like a pneumonia. And so having the lungs be clear tells us a lot of information, right? Same thing with the heart, right? So if she has an elevated heart rate, we kind of already know that. But with the fact that she has no murmurs is actually really important too, because typically with an endocarditis, if you have a bacteria that's sitting on the valves, and it usually disrupts blood flow, and so you would hear some murmurs sometimes. And then the rubs. What does a friction rub tell you if she were to have one on exam?
If there was a friction rub, it means that there's not enough like moisture.
So it means that the connection between, or the I guess the barrier, or the contact, sorry, between the heart muscle and the pericardium, so the lining of the heart is irritated, right? So you have this like rubbing type sound that sounds like kind of like it sounds scratchy. And so that would tell us if there's something like a pericarditis or like inflammation of the lining of the heart. And so the fact that there isn't anything there is not diagnostic, right? We can't say that it's not a pericarditis, but it makes it a little less likely. So the fact that her physical exam is pretty normal tells us quite a bit. Okay. So I think we kind of exhausted the physical exam part. And so what is our differential diagnosis then? So you guys can do, let me see here. I think I'll kind of list these off. If you guys want to react with it with like a thumbs up to click on it, we can do that. So is an aortic dissection possible here? Or is it likely? Doesn't look like anybody's going for it. So I agree it's not as likely. What about a pneumonia? Is this a possibility? Should we add it? I would say possibly. No?
Well, he didn't have any rubs or any like breathing sounds, abnormal breathing sounds or infections.
That's true, but the patient did have fever and shortness of breath. So I would keep it in there. The COPD exacerbation, that's chronic obstructive pulmonary disease. So she doesn't have a history of COPD, so I'd say it's less likely. Costochondritis, it's that inflammation of the connection of the ribs to the sternum, and so that cartilage area that being inflamed, I would say it's a little less likely as the cause of her pain, because it wouldn't necessarily cause the shortness of breath or I mean, I guess if it's really painful, it can cause tachycardia. What do you guys think? Yes or no?
I think it's not costochondritis because usually with costochondritis, I think it doesn't get worse with exercise. It
That's
just
true.
comes and goes.
That's true. So we can keep it off. GERD, I don't think it's going to be contributing to her symptoms. Pulmonary embolism. Yeah, so I would say, yeah. Okay. Anxiety. Is the anxiety going to be causing her symptoms? It's possible. It's possible. I don't know if I would put it as like the top differential diagnosis for her. And MI, we kind of talked about, yes, it's possible as well. Minal, did you have a question or no?
No, I can't find the thumb, so I'm using that.
Okay, no worries. No worries. So I would put an MI on there. Myocarditis, I mean, it's a little less likely. That's basically an inflammation of the heart muscle itself. I can't think of a reason why she might have myocarditis. Severe aortic stenosis, she's kind of out of the age range for aortic stenosis, so that's just a narrowing of the valve area of the aortic valve on the heart. A lot of times we see that when patients get older, the aortic valve becomes more stenotic. It becomes less able to open and close normally. So I wouldn't necessarily think aortic stenosis. And then viral pericarditis, she didn't really have, I mean, it's possible with the fever, but she didn't really have a history. Usually have a preceding history of an infection. So a lot of times somebody will get an infection, and then a bit after that, they'll develop this chest pain. I'm going to just say yes, because I'm not sure, to be honest with you guys. Okay, so we won't, for the sake of time, we won't go through everything. We'll just go through the ones that we got wrong. So we didn't put costochondritis, and they're saying it's a common cause of chest pain, so we should have put it. And then myocarditis, because the patient has viral symptoms and chest pain, myocarditis should be included in the differential. So I guess if we put viral pericarditis, we should have put myocarditis as well. MI is dangerous and common, and it should be considered. Although she's relatively young without any risk factors, the history of cocaine use may increase her risk. And then women may have atypical presentations of MI. And then pulmonary embolism is common and dangerous. It causes chest pain and shortness of breath, should always be considered. Okay, so let's go to the next. So our immediate next steps. So Shivani, I'm going to have you help me with this one.
Okay.
What is essential to do before the patient leaves the ER? So are we going to get a blood gas?
No.
I actually would. So the blood gas lets us know how well she's oxygenating, if she's having a problem exchanging oxygen for carbon dioxide.
Mm-hmm.
So it's actually a really good test. So I usually say whenever a patient comes into the ER with shortness of breath, you should always consider an arterial blood gas, because it'll give us a good understanding of where the patient is in their acid-base status. It will also let us know if her it will help us characterize what type of issues potentially causing shortness of breath. And
so you always do it?
I don't always do it. So if I'm very certain that this patient has a DVT, I wouldn't necessarily do it then, or a PE, sorry. And then also if I'm like, this patient has an MI, I'm more worried about getting her to the cath lab. So I wouldn't always do it.
Okay.
Would you get a chest x-ray?
Yes, I would.
Okay, portable or posterior, anterior, and lateral?
I don't remember seeing if the patient could like walk or not, but I think just like they can go and get posterior, anterior, and lateral.
So I would probably do portable, just because it's faster. It gives us a lot of good information, and they would have to go down to radiology for the most part to get a 2-view chest x-ray. So in the ER, we usually will just do a portable. We wouldn't do a 2-view unless it's like we think that it's really necessary for our diagnosis. CT scan of the chest.
No, because if you're not going all the way to do the other x-ray, you wouldn't do a CT.
So so actually I would. I guess it's before the patient leaves the ER. Because we're saying that a pulmonary embolism is a possibility in this patient, I would get a CT, because that would be probably the best way to diagnose the pulmonary embolism. Would you get an EKG?
I don't think we saw anything wrong with her heart, but it wouldn't hurt to just check.
Yeah, especially if she's having chest pain, we should do it. What about D-dimer levels?
We didn't think she had a clot, but possible.
Yeah, so she was having that intermittent leg swelling, and if
Mhm.
we're trying to rule out a pulmonary embolism, we probably would get a D-dimer. Honestly, I don't know if I would waste time getting a D-dimer if I'm thinking pulmonary embolism for this patient. I would I wouldn't wait on the D-dimer to come back. We can get it, but I wouldn't wait for it.
Yeah.
Blood counts, would we do that?
Yes.
Okay. And then BNP. Do you know what that is?
Yeah, it's signifying for the ventricle stretching, right?
Yes. So in a patient with heart failure, we would have elevated BNP. Do we think she has heart failure?
No.
No. Okay. I agree. What about troponins?
Yes, we would do it.
Yeah.
Because what if she's having a heart attack?
Exactly. And then complete metabolic panel.
It doesn't hurt.
Yeah,
You don't need it. It's not
I would-
emergent,
What was that?
right? It's not like an urgency to get that.
It's actually super important. Do you know why?
The lipid levels would put you at risk of something.
Not lipids.
Ions.
So the electrolytes are important. Crystal, why is the CMP really important?
It would show if she's still using heroin.
No, it wouldn't show that. So the CMP is going to show us the electrolytes. It'll show liver functions. It'll show kidney function. It'll show us glucose. What in there is super important? Anybody can answer. So if we're going to get a CT,
platelets, clotting, something like that.
that'll be in the CBC. But if we're going to get a CT and we're going to get a CTA, which uses contrast.
Kidney function.
Kidney function. Kidney function is super, super important in this patient to see if we can actually do a CT pulmonary angiogram.
Okay. Yes.
Okay. So that's super, super important. But they say it's not important. What?
Sorry.
Little no diagnostic information, evaluation of chest pain. There are no clinical reasons to suspect electrolyte abnormality, but it doesn't matter. I would disagree with this. I think that the kidney function is really important. The D-dimer levels are useful to evaluate for pulmonary embolism, yeah, but you wouldn't necessarily wait for that. O2 sat is normal, and so they're saying don't get a blood gas. I would agree with that if I think that if I think I have a low suspicion, if I have a higher suspicion for pulmonary embolism, I wouldn't necessarily get a blood gas. And then they said the patient should have simpler studies first and not necessarily a CT scan of the chest, which is, I guess, true. So they basically what they're trying to do is they're trying to get a D-dimer first and see if it's elevated. If it's elevated, then they're going to say, okay, we'll get the CT scan of the chest, which is reasonable, which is pretty reasonable. This is the only thing I would disagree with. The CMP, I would get the CMP. I think it's important. And that's just thinking in the future what we would need to get. And so here are the test results, right? So the serum D-dimer level is 395. The normal is below, I think that's the normal range. So normal is less than 300. Hemoglobin is 9.7. So that's on the lower side. Platelet levels are 330, which is normal. White blood cell count is 10.6, which is normal. And then troponin is 0.05. The normal is less than 0.1. So let's go with Philip. What's your interpretation of the lab results? Or Madeline, what's your interpretation?
I think all of
the results, like the serum D dimer level, seems normal. But the hemoglobin, I think it's a little low.
So yeah, the hemoglobin's on the lower side, but we know that she has a history of anemia. The D dimer is actually a little elevated, right? So the normal's less than 300, hers is 395, so she is a little elevated. What would you want to do? We kind of talked about it within the last section. What would you want to do next for her?
Like test wise,
Mm-hmm.
I don't really know.
No worries. So I would actually want to do the CT scan at this point. If she's having a D dimer level that's elevated, D dimers are not sensitive or not specific for a clot, right? It can be elevated in patients that have just inflammation in general, so like an infection. But I would want to get a CT scan at this point. Her troponin level is normal, so I would be a little less. I would think a little less likely a heart attack. Although if it was recent onset, it takes time for the troponin levels to increase. So I wouldn't necessarily say the heart attack is ruled out, just a little less likely. Okay. So EKG is really small. Let me see if I can blow it up. And it's really pixelated now. Okay. So they're asking what the interpretation is of the EKG. Does anybody want to try it and tell me which answer is correct while I look through it too?
I can try.
Go for Shivani.
Okay. So, should I just go with the answer choices and see which one I think that there is?
So they're all saying sinus tachycardia. So I mean, what is the rate?
I messed up the number. 1 second.
No worries. Emma, what's the rate?
18 times 6.
18 times 6. So that is like 108. So yeah, she is tachycardic. Either Emma, Shivani, what are your thoughts on one of these? And this is actually pretty hard. So I wouldn't expect you guys to get it necessarily unless.
Needs to.
So we'll go through all of them. So does she have diffuse ST segment elevations?
I don't see any.
I don't see any either. All the ST segments look pretty good, although it's super pixelated, so it's hard to say. So if she doesn't have diffuse ST segment elevations, what about in leads 2, 3 AVF? So that's 2. That looks okay. 3 looks okay. AVF looks okay as well. So I wouldn't choose those 2. And they don't look depressed either, so not those 3. So then by default, sinus tachycardia with S1 Q3 T3 sign.
What does that mean?
So S1, so it's a deep S wave in lead 1. So QRS, right? So that's that bottom part. So she does have it kind of going more farther down than normal. Q3 is, where's 3? So Q is kind of deep there too. So she has that, and then T3 as well. I think it's T-wave inversion. I'm not sure, but it's hard to see here. So this is that classic sign of a pulmonary embolism. So if a patient has an S1Q3 T3, that represents strain on the heart, and it's something that you'll see on like board exams and all that, but you really never see in real life. The most common finding on EKG for a pulmonary embolism is just sinus tachycardia. So I think that's what they're trying to show, that she has the S1Q3 T3, and so The other three are not the answer. It looks like they're saying that she has a pulmonary embolism. Let me see. That's 1, 2, 3. Right, yeah. So it's a T wave inversion. So it's the deep S wave in lead 1, and in lead 3 you have a deep Q wave. So and then a T wave inversion on T3 on the third lead as well. Again, I've never seen this. But if you do see it, it's pretty. I mean, this is really hard to see. You can say that there is some right heart strain, and that can be a sign of a pulmonary embolism. And if you think about it, the right side of the heart is not as strong as the left side. If you have a clot going to the pulmonary arteries, right? So the clot is being dislodged going to the lungs. Now you have this blockage here. So the resistance within these vessels goes up. And so your right side of the heart has to push even harder against these clots to get blood to the areas that it's supposed to. And so that shows strain on that. The EKG is supposed to show strain on the right side of the heart. All right. So given the previous finding, what's the most appropriate steps to guide diagnosis and treatment of this patient? And anybody can answer. So is it a cardiac catheterization, CT scan of the chest with IV contrast, pulmonary function testing, or ultrasound of the legs?
CT scan of chest?
Of the chest with IV contrast. The ultrasound is important. I wouldn't say that. I guess it would be important to do as well, just to see if there's a blood clot in the leg. It won't change our management if we see a clot in the lung, but it would be important. They say it's not important. Okay. Can wait pending the results of the CT scan, given her ongoing chest pain, lack of current lower extremity symptoms. That's true. She didn't have any swelling or redness in the leg. And I would agree. I wouldn't wait to get an ultrasound. I would go straight to the CT. And so this is the CT of the chest with IV contrast. And it shows a filling deficit in the bilateral upper and lower segmental pulmonary arteries on the pulmonary arterial phase. So all that means, so in the interest of time, I'll just kind of go through this. So all this means is when you inject the IV contrast, it'll go to the heart, and they try to time the CT scan to align with the pulmonary artery filling with contrast, right? So if we look here, these are the pulmonary arteries right here, these that are kind of branching out this way and this way. And if we look, there is a clot right here. So we see all this white here, and there's a lot of gray here. So there's something here that's obstructing the flow of contrast. And so we see some of the contrast leaking out, but then we see a filling defect again there, where it becomes abruptly gray like that. So we see all the white here, filling defect, and then a little bit of contrast afterwards. So we know that it's not completely obstructed, but there does seem to be a clot, in these areas. Let me see if there is another picture that we can show that might be a bit more clear. So something like this, right? Pulmonary artery, gray here, right? This is all clot that's not allowing for the contrast to fill this artery right there, right? So you compare that to what we're seeing here. It's not as clear, but we do see that gray. Any questions about that? Does that make sense? Okay. So at this time, what's the most likely diagnosis? And pulmonary embolism, everybody in agreement? Yes. Okay. And so that was right. So treatment orders. So there's a blood clot. How are we going to treat it? And it can be general. It doesn't have to be one of these. What are your thoughts about how we would treat this pulmonary embolism?
Warfarin?
Yeah. So
Vitamin
what's
K.
the thought behind it? What are we trying to do?
We're trying to break up the clot and open it up again, but not make the clot go to the brain. I don't know.
No, actually, no. So we're not trying to break up the clot, right?
Mhm.
I think somebody else raised their hand. Basharna, what are you thinking?
I think you would want to prevent more clotting from happening.
Yeah. So it's not exactly. So it's not necessarily that we're trying to break up the clot itself. So that would be something like alteplase, alteplase, right? So alteplase is something that will break up the clot. But you're basically breaking up clotting everywhere if you inject this medication, and so you're going to be really, really high risk of bleeding. So we usually don't do that. We will usually. You were right, Shivani, about the warfarin, but it's not to break up the clot; it's to prevent the clot from growing. Because once you have a clot, you're more prone to having that grow because your body is always in a balance of making clots and breaking them down. And so what we try to do is we try to stop the making clot portion so your body can focus on the breaking it down portion. And so you're right with the warfarin, but we don't start just warfarin by itself. Do you know why?
Does
Me?
it decrease heart rate?
What was that?
Never mind.
Anybody can answer. Well, why don't we just start warfarin? And it's a hard question. I don't expect anybody to know.
You give it with
Couldn't
vitamin
it-
K.
Anybody? Jeanette.
Oh, I was gonna say you don't give warfarin on its own because since it's something that stops the production of clotting. Could it like cause like other issues if it's not given with something to like mitigate it?
Not necessarily. It's very specific to the pharmacology of warfarin. Shivani, do you know?
I just remember Dr. Kanpal saying something about like vitamin K epoxide helps with the warfarin breaking up something.
So warfarin, the way that it works is, yes, it does stop stop clotting with vitamin K, right? It works through the vitamin K pathway, but you do have you also have inactive, and it has to do with the clotting cascade. Basically, what ends up happening is in the beginning of when warfarin starts, you actually become more hypercoagulable. You have more of a propensity to clot because of protein C and S inhibition, and so. So in this clotting cascade, you also get. Let me see if there's a good picture. So warfarin works on 9, 7A, 9A, and protein CNS. And this protein CNS actually makes you when I think it's when you inhibit it, you become more prone to clotting. And so in the beginning, you actually have to treat at the same time with heparin. So the heparin will help bridge you to the time when all the other factors are appropriately inhibited. So you actually have the anticoagulation. So it just takes time for warfarin to work. And within that time frame, you need to give something else. And so that's why the heparin infusion is really important in the beginning of when you're starting treatment. And hopefully that makes sense. There are newer anticoagulants that don't necessarily need that heparin bridge, but for this one, we would need that the heparin, and then we would want to admit the patient for further treatment. Tylenol we would want to give for chest pain, and then everything else was right. Okay. So what are the most common vital sign abnormalities in patients with pulmonary embolism? Anybody can answer. Fever, hypotension, hypoxia, tachycardia, tachypnea. And it could be more than one.
Was tachycardia one of them?
Tachycardia is one of them. What else? We can see hypoxia. I don't know if it's a common vital sign, but we can see some hypoxia. So that means that your oxygen saturations become lower. Usually, though, if you're hypoxic, you're gonna be what am I trying to say? If you're hypoxic, the burden of the clot is very high. So I don't know if it would be a common vital sign. It would be common in a pretty big pulmonary embolism. What about tachypnea, breathing fast? Is that?
Yes.
Yes, I would agree. So you're going to be breathing a bit faster than normal. Low blood pressure, you're usually going to see if you're having a pump failure. So if you're having a big enough clot that the right side of the heart is not able to pump past it, your blood pressure is just going to drop. So I wouldn't say it's a common cause. You actually can get a fever in pulmonary embolism. Again, I don't think it's common though. So they're saying hypoxia is just not a vital sign abnormality in patients with acute pulmonary embolism. I would say it's not a common one if it's not a big pulmonary embolism. So yeah. Which of the following drugs are approved for outpatient treatment for pulmonary embolism? This is probably not as relevant to you guys. We wouldn't treat with aspirin; it's not strong enough. Dabigatran is Pradaxa, and that one we can treat for outpatient for pulmonary embolism. Enoxaparin is Lovenox. It's an injection that we give to anticoagulate. We would use it. Enoxaparin and Lovenox is our treatment of choice in patients that have pulmonary embolism or embolism in general because of cancer, right? So if a patient has a blood clot because of cancer, we want to treat with Lovenox. And then fondaparinux is a newer anticoagulant. I think it's a pill. I'm not sure. Yeah, I guess it is. I've never used it just because it's expensive. So which of the following is a component of the Wells criteria for pulmonary embolism? I don't. So first degree relative history of pulmonary embolism, I don't think is part of it. Heart rate above 100. I think that's a sign of pulmonary embolism. It's not part of the Wells criteria for PE. Hemoptysis, coughing up blood. I don't think so. To be honest, I'm blanking on what the actual criteria is. And then I know immobilization is important. MD Calc is my favorite, so use this whenever you guys get it. Whenever you guys need like calculators and stuff. So clinical signs of DVT, PE number one diagnosis are equally likely. Oh, I do remember this. Heart rate above 100. So yeah, that is one of them. Immobilization, previous history of PE or DVT. She doesn't have that. Hemoptysis is one of them too. And I got all of them wrong. And then malignancy. Okay. What? They're saying it's wrong. I don't know. That it's MD Calc says it's part of the criteria. All right. So about the case. So PE is the occlusion of one or more pulmonary arteries by thrombi that originate elsewhere in the body, typically large veins like the legs, the veins of the legs or in the pelvis. Like we talked about with the virtuous triad, risk factors are conditions that impair venous return, so things that don't allow blood flow to actually happen. Endothelial injury or dysfunction, underlying hypercoagulable states like malignancy. Symptoms are not specific, but they include shortness of breath, pleuritic chest pain, so pain as you breathe in and out because of inflammation of the pleura. And in severe cases, lightheadedness, presyncope, syncope, or cardiorespiratory arrest. Like I said, big pulmonary embolisms that that strain the heart to the point where the pump is starting to fail, it can cause syncope or presyncope and a failure of the pump system. Non-specific signs include high respiratory rate, high heart rate, and then in severe cases, low blood pressure. So you diagnose with a CT angiogram. If you have poor kidneys, you actually can't do a CT angiogram because it'll mess up your kidneys even more. So we actually do something called a VQ scan, which is a ventilation perfusion scan. It's not as good at diagnosing PE, but it's what we have in patients that we're not able to do CT scans. And if anybody's interested, I can kind of go through what a VQ scan looks like and how to read it. But it's kind of probably we're running a bit short on time. And then if you really need to, you can do pulmonary arteriography, which I believe is just direct visualization of the pulmonary arteries with dye and contrast, kind of like what an angiogram in the heart would look like. I've never seen that though. Treatments with anticoagulants, and if the clot is big, we would do clot dissolution with thrombolytics or surgical removal. So if you have a really big clot, your patient is crashing, you would want to do the TPA, the medications that will break up the clot, or you can remove it surgically. So a lot of times it'll be with like a thrombectomy. You'll go into the vessel and actually extract the clot. If you can't anticoagulate a patient, if you're not able to use warfarin or Pradaxa, Lovenox, anything like that, you can put a inferior vena cava filter. So that is a filter that sits on the inferior vena cava and it will prevent clots from going up into the heart. It's not a really great treatment. We only use it as a last resort, and it's not permanent. It shouldn't be permanent. Preventive measures, mechanical compression of the legs, anticoagulants for hospitalized patients because a lot of times patients are immobile in the hospital for long periods of time. Minal, do you have a question?
Yes, I wanted to ask you, would it be important to ask in the past, not the past medical history, but like to get knowledge of like what medications the patient has taken before coming in to the hospital?
Yeah.
And like in the situation, like would it be important to know if they've taken aspirin since it's a blood thinner?
The aspirin is not as important unless you're taking very high doses of aspirin. And even then, I don't know if that would stop the treatment of a pulmonary embolism. Because even if they're taking like an aspirin 81, you would still treat the pulmonary embolism the same, just because, yeah, there's going to be a slightly increased risk of bleeding, but the risks of the patient developing more of a larger pulmonary embolism are a lot higher. And so, yeah, but it is important to get that medical history in general. So patients diagnosed with unprovoked PE should get a screening for malignancy. So you want to make sure that there is no cancer. Recurrent emboli should have a workup for hypercoagulability. So genetic disorders that would potentially make them more prone to clotting, like we kind of talked about before. For this patient, she didn't have any cancers. She was diagnosed with a DVT in the left lower extremity 2 months later, despite being therapeutic on warfarin. She had that's interesting. So even though she was on warfarin, she still had a clot, because a lot of times, like we said, we're not breaking down the clot, but in the left lower extremity, when they checked again in 2 months, she still had the clot there after being therapeutic on warfarin. So in the iliac vein, so one of the veins that carry blood from the leg in the pelvic area up to the heart, there was compression from an enlarged uterus because of her fibroids. So she underwent hysterectomy with no recurrent events. So that's super interesting, because iliac vein compression. So in this area here, it wasn't because of the artery, but she had compression of the vein because of the uterus. And so let me see if there's a good picture. It's kind of, I guess, is a decent picture. So the uterus kind of sits in this area. The veins are here. She probably had a large enough fibroid that was pushing on the vein here, making the blood flow decrease. And anytime you have blood flow that is decreased and blood isn't moving the way it's supposed to, you have an increased risk of clotting. So that's actually a really interesting case. And so once she got the hysterectomy, her symptoms resolved and she didn't have a clot anymore. So really cool. Okay, questions about that? That's at the end of the case. No. Do you like this format where we're kind of solving the case together and you kind of see my thought process of it? Or do you want to do more kind of what we did before, a mix of it? What are your guys' thoughts? Yeah. Anybody?
I think it was a pretty good change, and it was really awesome because we kind of can see how you go about cases, I guess, in real life. But I also really like the other one, so I guess a mix of both would be really cool.
Okay. So then, yeah, we may do a mix of both. Other thoughts? Mix, Vivian saying mix. Okay, we'll do a mix. I do like the other format as well, just because I'm able to kind of get those very specific teaching points that I want to point out. So having a mix, I think, would help. Okay, sounds good. So for this one, so for this case, I'll put some questions on once I figure out the site. I'll put it there so you guys can get credit for today as well. They'll be pretty simple. And I already have the questions set out for the last session. If in the end I can't figure this out, and it's going to take longer than I expected, then I will just send you like a Google form or something like that. So just be on the lookout for it. I know in the past, just because of the way that the program has kind of been rescheduled, I'll send you guys an email just with an update on what we're doing. Okay. Questions at all for me? If not, then you guys are good to go. I'll stay on until everybody's gone in case you do have any questions. Yeah.
Dr. Boss, I had a question. So I know that the site's been down and it hasn't been working, and so for those of us who just since I just joined and I wanted to do the other sessions and do the credit for those, will you be, if you can't figure out the site before this whole thing ends, will you make a Google form for those ones as well?
Yeah, I'll figure it out. I'm gonna try. The thing is, it'll take a few hours to probably really try to figure out what the incompatibility is with the new update. So I'm hoping I'll do it, but if not, yeah, I'll be able to do that. What I will say for everybody for the next sessions, just because there may be, and I'll send an email as well, just because there may be more of an abdominal, cases. I want you guys to look through the abdominal series on YouTube, okay, because I know the course is down right now. And I'll send you guys an email with that too. But yeah, I'll make sure that you guys get the credit if you need for it as well, okay?
Thank you so much.
No worries.
Can I ask you a question that relates to the case?
Yeah, sure.
Would you be able to go over is her fibroids in her uterus related to the clots that she has? What's the link between them? Why did they say that?
So let me see. So basically, you have trying to see if I can find a good picture. So if we remember kind of what are the causes of clotting, I guess this is one of the better ones. So people clot because they have because of virtuous triad, right? So you either have stasis, you have endothelial injury, or you have hypercoagulability. And so for her, they did the screening. We know that she's not hypercoagulable. She doesn't have cancer, right? For her, it's because of stasis, right? So if we think of the uterus here, and this is a normal uterus, but if we look at what uterine fibroids look like, these can become gigantic, right? These can be really, really big. These are not cancerous. They're benign growths, but they can be really big. And if you look at the proximity of the uterus to the veins, the iliac veins, if you just imagine a gigantic fibroid just pushing out from here and pushing on the vein, you're not getting good blood flow up to the heart, right? So the vein is collecting all the blood from the leg. It's not able to go up through the iliac vein because of that fibroid. And so the blood in the leg veins themselves are not moving the way they're supposed to. So blood that doesn't move tends to clot. And so she developed a clot in that leg because of that compression, because of that lack of flow back to the heart. And so once that clot dislodged and went back to the heart, it was pushed into the pulmonary arteries and caused the pulmonary embolism. Does that make sense?
Yes.
Okay.
Cool. Thank you. Have a good day.
Other questions?
I had a question about one of the images that you pulled up for the heart during PE, I think it was, and the damaged portion of the heart was dark. What causes that dark color?
So this is just trying to show that this part of the heart is damaged and dying, right? So if you have a large embolism and you can't get blood to that portion of the heart, you can have ischemia of the lung. Sorry, you can have ischemia of the lung tissue, and that portion of the lung can become damaged. That's when you start getting the coughing up blood because the tissues start to break down. You start bleeding into the lung, and so the lung gets two different blood supplies. It gets a blood supply to the tissue itself, which is from the small arteries going to the lungs, like to the lung tissue, and it also gets the blood supply from the heart that it's supposed to oxygenate and send back to the heart to pump to the rest of the body. And so if you have a big enough clot and you're cutting off the blood supply, you get damage like this. You get the breaking down of the tissues, you get bleeding into the heart. And so that's all this is trying to, into the lung, sorry. This is all that it's trying to represent. It's just that ischemia portion. Does that make sense?
It does. Thank you, Dr. Nakvi.
No problem. Other questions? I think somebody said for potential treatments, why was warfarin preferred over heparin in the long term? So warfarin is a pill. You can take warfarin outpatient. Heparin has to be infused. Lovenox, so that one is going to be IV. So Lovenox you can inject. So that one you can inject in the belly. So like I said, for patients that have cancer, they would have to do the injections, but that's a syringe that you're able to inject. For the most part, if we can do a pill outpatient, it's better than injections. But that's the only reason. You'd want to do warfarin with heparin initially, and then once you complete that bridge portion, you can just continue warfarin by itself. Patients will go regular lab screening just to make sure that the level of the warfarin is appropriate, and they're at a good state in terms of the amount of anticoagulation we want. That's why the newer anticoagulants like Pradaxa are better, because you don't need to do that regular blood testing that you would have to do with something like warfarin.
Thank you so much, Dr. Nakvi. Have a great day.
You too. Other questions?
I just wanted to say thank you. I'm going to leave now to go study, but thank you so much.
Sounds good.
Okay, bye-bye.
All right.
Thank you, Professor. Have a nice day. Sorry.
You
Thank
too.
you, Monthly.
No problem. Okay. Crystal, do you have a question? Okay, sounds good. Thank you. Thank you everybody for joining.